Dear viewers, in this video, I will be discussing how we ventilate patients with ALI, ARDS in our ICU. While broadly our strategy is derived from guidelines, there are some nuances involved. I am Dr. Sunil Garg from Essentials of Acute Care. Before we go into the details of ventilatory management, we understand in brief what is ALI and ARDS. ALI and ARDS are characterized by rapid onset respiratory failure following a variety of direct and indirect insult to the parenchyma or vasculature of the lungs. Current therapy primarily emphasizes lung protective mechanical ventilation and a restrictive fluid management strategy plus standard treatment of the initiating insult or underlying disease. The mortality due to ARDS is substantial. We provide lung protective ventilation to all patients with suspected or confirmed ALI-ARDS. What is lung protective ventilation? Lung protective ventilation encompasses low tidal volume ventilation, means tidal volume between 4 to 8 ml per kg of predicted body weight and plateau pressure 30 cm of water or less. How we initiate ventilation? We initially set the ventilator with the following settings. We keep initial tidal volume at 6 ml per kg of predicted body weight. So, in most of our adult patients, tidal volume varies between 320 to 380 ml. We keep initial PEEP 5 for mild ARDS, means when PF ratio is between 200 to 300, and 8 for moderate to severe ARDS, means when PF ratio is less than 200. We also keep initial PEEP 8 in patients with the poor chest wall compliance like obese patient or patients with abdominal distension of any etiology. We keep initial oxygen concentration at 95% and respiratory rate between 20 to 30 per minute to match baseline minute ventilation. In most of our patients, we initially apply volume limited assist control mode. After initial ventilatory settings, we monitor vital parameters and arterial blood gas, more specifically partial pressure of oxygen, carbon dioxide, pH, and lactate value. We also monitor ventilatory parameters like peak, plateau, and driving pressure. We keep watch on urine output and any ventilatory dyssynchrony present. If patient is on volume assist control mode, we also monitor stress index. While initiating and continuing with ventilatory therapy, we take into consideration multiple factors which directly or indirectly affects our ventilatory management. If patient's ARDS is associated with any neurological disease or injury, it may impact strategy of permissive hypercapnia. Permissive hypercapnia may also cause or worsen hemodynamic instability, and patients with poor cardiac functions are more at risk. Associated metabolic acidosis in a patient with respiratory acidosis may profoundly decrease pH. We also consider if patient has obesity or abdominal distension as it impacts chest wall compliance, hence plateau and driving pressure. We accept plateau pressure more than 30 and up to 35 if chest wall compliance is compromised due to obesity or abdominal distension. We accept permissive hypercapnia as an outcome of ventilatory strategy as long as there is no contraindication or adverse effects. There is no arbitrary upper limit of partial pressure of carbon dioxide. We accept partial pressure of oxygen 55 mm of mercury or more and saturation 88% or more and respiratory rate up to 35 per minute if it helps in reducing partial pressure of CO2 as long as there is no auto PEEP. During ventilatory management of ARDS, we do not allow following things to happen. Firstly, we do not allow auto PEEP to develop or hemodynamic instability to occur consequent to permissive hypercapnia. Secondly, we do not allow plateau pressure to increase disproportionately on increasing PEEP. It means static compliance should improve on increasing PEEP. Thirdly, we do not allow plateau pressure to rise above 30 in patients with normal chest wall compliance and driving pressure to go beyond 15 cm of water. We do not try to normalize CO2 for patients who are receiving tidal volume of 6 ml per kg even if plateau pressure is less than 30 cm of water as long as it is safe. After initial ventilator settings, we monitor the patient constantly. We set the tidal volume after an initial value of 6 ml per kg based on arterial blood gas, plateau pressure and driving pressure. After an initial PEEP of 5 to 8 cm of water, we increase PEEP based on oxygenation, hemodynamic stability and the most appropriate static compliance stress index. We reduce the FiO2 to minimal possible value to maintain saturation more than 88 to 90% and partial pressure of oxygen 55 mm of mercury or more. We set the respiratory rate up to maximum of 35 based on CO2 level in an attempt to increase mint ventilation without developing auto PEEP. With regards to management of hypercapnia, if patient has high CO2 and contraindication to hypercapnia or adverse effects are evident and plateau pressure is less than 30 cm of water, we increase tidal volume from 6 ml per kg to 6.5 to 7 ml per kg. But if contraindication or adverse effects of high CO2 are not evident, we do not increase tidal volume even if plateau pressure is less than 30 cm of water. Regarding ongoing ventilator management, we decrease the tidal volume from 6 ml per kg to 5 ml per kg or further down to 4 ml per kg if plateau pressure increases more than 30 cm of water in patients with normal chest wall compliance. If patient has high CO2 with 6 ml per kg and plateau pressure is 30 cm of water or more and contraindication or adverse effects of high CO2 are evident, we consider extracorporeal CO2 removal. We increase the PEEP in all patients of moderate to severe ARDS from initial value of 8 based on not only PO2 value but oxygen delivery and improvement in the static compliance with the increase in PEEP. If patient has hypercapnia and tidal volume is less than 6 ml per kg and plateau pressure less than 25, we increase tidal volume to make it 6 ml per kg or plateau pressure 25 cm of water. Regarding management of pH, if pH is less than 7.15 due to combined respiratory and metabolic acidosis, we administer sodium bicarbonate irrespective of whether acute kidney injury or failure is present or not. But if pH is less than 7.15 due to respiratory acidosis alone, we administer sodium bicarbonate to raise pH only if patient is hemodynamically unstable and requiring initiation of vasopressor or increasing dose of vasopressor to maintain mean arterial pressure. We consider prone ventilation in those patients with moderate to severe ARDS who continue to remain hypoxic despite lung protective ventilation, means when the PF ratio is less than 100 to 150 on 100% oxygen. We use prone ventilation early during the course of therapy provided there is no contraindication. We consider increasing IE ratio in patients with refractory hypoxemia occasionally. We monitor for ventilator dysynchrony and if double triggering occurs frequently, we prefer to increase level of sedation or add new sedation than increasing tidal volume. If increasing sedation does not work, We increase tidal volume as long as P plateau remains below 30. So to summarize the ventilatory strategy of ALI ARDS, we provide lung protective ventilation in all our patients. We accept permissive hypercapnia as long as there is no contraindication or adverse effects of high CO2 are present. We do not consider any particular value of CO2 as cutoff value. We monitor for the auto PEEP, and in addition to plateau pressure, we monitor driving pressure in all our patients. We optimize PEEP based on oxygen delivery and static compliance, and we reduce oxygen to minimal possible concentration to keep saturation more than 88% and partial pressure of oxygen more than 55 mm of mercury. You can find the link of my videos on permissive hypercapnia, auto PEEP and how to optimize PEEP in description and comment section. Here I finish. Thanks for watching this video. I will appreciate your feedback, suggestions or comments. See you in my next video on prone ventilation. Till then, bye and take care.